Okay, welcome everyone. As I said, my name is Amber Collins, and I'll be one of your hosts today. Um, and I'll get started with a few housekeeping items. This session is a webinar, and all attendees are muted, and video is turned off. Please use the Q&A box for any presenter questions you may have. The questions will be answered at the end of the session. This session is being recorded and will be available to view on our website and YouTube channel. To be eligible for CEUs or certificates of attendance, you must be present for 90% of the session. Our Zoom tracks those minutes. You do not need to enter your contact information into the chat. As I said, Zoom tracks all of that for us. Please use the same email to register and to log in to each learning session. And you will receive an email following today's trainings with instructions to access the online CEU system. And certificates should be available by March 26th. Sorry, I didn't mean to hit stop share.
Hello, everyone. I am Melissa Hopkins. I wanted to also add that there is a Q&A button at the bottom of your screen. Please put any questions that you have in there. There will be a Q&A session at the end of the presentation. I have the very great honor of introducing our speaker today, Dr. Roberto Sanchez. Dr. Sanchez completed his medical school education at Texas College of Osteopathic Medicine, his general psychiatry residency at Baylor College of Medicine, and his addiction psychiatry fellowship at Yale University School of Medicine. Currently, he is assistant professor of psychiatry at Baylor College of Medicine and practices as an addiction psychiatrist with the Harris Health System. He has an interest in reducing barriers to care for addiction treatment and improving screening and recognition of substance use disorders. It is my very great pleasure to introduce Dr. Sanchez.
Awesome. Hello, everybody. Thank you so much for having me. I'm really excited about this, and I really hope that it's something that's helpful. And of course, we have the Q&A at the end. Really looking forward to that. If anything comes up in the moment, feel free to let me know. I know sometimes we can kind of forget what we were going to ask when time passes and things. So I have no problem with being stopped, or if there is any point of clarification or anything. But I think, so I will try to share my screen now. And just let me know if you have any trouble viewing it. Let's see. Okay, everybody can see that all right? Perfect, cool, all right. Well, let's get started. So today, I'm talking about substance use disorders in late life. No disclosures or anything like that. And here are some of our objectives. Let me see if I can, there we go. So I'm hoping, at the conclusion of this, that we can have a better understanding of how addiction, how substance use disorders impacts individuals in late life. We'll have some discussion about the screening tools that we have for addiction in late life and sort of maybe the lack thereof. How to identify substance use disorders in late life and how that may differ from younger folks, especially when looking at the DSM-5 criteria. And then we won't go too into the details, but we'll discuss some of the medications that we use to treat addiction and how that might change in late life. And of course, probably the most important, what are some of the psychosocial treatments that we can use to address addiction in this population? And first, I just want to start off with a little bit of note on language. In addiction treatment, language can be incredibly important. I think we can't ignore across all age groups how we have treated those who have struggled with substance use disorders historically. I think in the past, addiction treatment was seen as being fairly separate from medical treatment. If you presented maybe to an emergency room, you were often kind of referred to AA, and AA was a very sort of separate entity And oftentimes we kind of use this abstinence model and authoritative sort of way of just saying you have to stop, just you have to stop, and not really giving people tools or medications or ways. But with all that being said, I think we have historically kind of labeled people as an alcoholic or labeled someone as a drug abuser. And people have felt a lot of shame with that. And with that shame, it becomes really difficult to seek treatment, to come to the emergency room if you're struggling, um, to come to your clinic and tell your physician that you need help with your alcohol, opioid, methamphetamine use, whatever it may be. Um, so person first language is incredibly important, right? Acknowledging somebody as being an individual that struggles with an alcohol use disorder, not being an alcoholic. Just like, we don't really say a schizophrenic anymore. We say somebody who struggles with schizophrenia, avoiding it as being a label, but more so a part of their life and something that they struggle with. They've done studies to sort of suggest that when people were labeled as like a methamphetamine abuser versus somebody who struggled with a stimulant use disorder, they didn't get the same level of care. They didn't have the same outcomes. So this is still the same in late life. If somebody's kind of seeking care for the first time at the age of 65 or 70, we want to treat them with respect and speak about their struggles in a way that's empathic. Um, and briefly, there's a lot of different terminology in the literature. When you do kind of a literature review on addiction, not just in late life, but for all age groups, you'll see alcohol dependence, alcohol abuse, substance misuse, at-risk use, hazardous use. So it can be a little bit confusing. In general, when we hear substance misuse, it's when somebody's using it in a way that wasn't intended, maybe more than was intended, or for a reason that it wasn't prescribed for. When we hear at-risk or hazardous use, it's more so the use has gotten to a point that it's causing physical or mental problems and complications. So maybe they don't meet the full criteria for a substance use disorder yet, but it's causing some physical or mental harm. Um, and lastly, I mentioned that we don't really use a word like drug abuser anymore. And that's for what I mentioned, not labeling them as that, but also I think, we've come to understand that when we use the word abuse, we talk about physical abuse, sexual abuse, emotional abuse, animal abuse, and to liken that with somebody who's struggling to stop opioids. I think we can understand why that doesn't sound like we should be using the same word. So we have more so been using substance use disorder. Cool. And so kind of going into the older adult, prevalence, some historical factors, trends. This is an age group that I think has not always been incorporated in surveys, studies for us to really understand how substances are impacting their life and their health. When you look at studies, sometimes they categorize an older adult as above the age of 55. I think a lot of studies now are trying to kind of use 65 as a cutoff, 65 and older. But in general, just for the sake of completeness, we included in our literature review for this just 55 and above to get an understanding, especially because that age group currently represents about 30% of the US population. And of course, the baby boomer generation, we talk about this a lot, but this is people born between 1946 and 1964. They're going to be the largest group of older persons in the history of the US. And as a result, we really have this responsibility to understand what are the health aspects that we really need to have a good grasp on to treat this population, because we're going to be seeing them, of course. And just as a kind of slight background, of course, I'm an addiction psychiatrist, and I initially kind of worked on this with a colleague who's a geriatric psychiatrist, and we were trying to figure out how to create a lecture that sort of involves both of our interests. And we kind of just combined the two and did geriatric addiction, and that's kind of how this started and how this research sort of came to be a little bit. But the number of older adults is projected to exceed 72.1 million by 2030, which isn't very far away. Members of the baby boomer generation have the highest rates of early substance use and are more likely to continue substance use into later life, which is what kind of inspired, this lecture, understanding that this is going to be a group of patients that are going to need addiction care. Rates of substance use disorders in older individuals more than doubled from 2007 to 2020. We'll go into some of the reasons that might be here in a little bit. And the rate of substance use disorders in the current group of older adults is higher than any previous cohort of older adults. So we know that this is, kind of a unique specific issue for this group of people. And the number of older adults needing treatment for substance use disorders is increasing across all genders and racial ethnic groups. It's pretty common for us to say alcohol is bad for your health, right? We know that. We know it's not the best thing for you. But what are some of the specific things that seem to be comorbid that occur with substance use in general, not just alcohol? We see higher rates of hypertension, hepatic disease, chronic pain. And we know that as we get older, even lower levels or lower doses of substances can exacerbate underlying medical or mental health conditions. So even if somebody's been drinking the same amount their whole life, with age and with changes, that same amount of alcohol might have greater effects on their overall health. And then just kind of an interesting note, admissions related to opioids, stimulants, and cannabis have been increasing in older adults. And I think, alcohol and tobacco still are the highest amount of substances used overall, but cocaine and heroin and fentanyl are now being frequently reported in this older age group. And so I kind of touched on this a little bit, but older adults are particularly vulnerable to the effects of substances for a variety of reasons, decreased percentage of lean body mass, decreased total body water. There's an increased blood-brain barrier permeability, slower metabolism of certain drugs or alcohol, altered way of sort of breaking down and metabolizing, and how, not just metabolizing, but how long they stay in the body and bind to receptors, and age-related changes in the brain. So these are all reasons why, even if it wasn't necessarily an increase in the amount of substances that were being used, it may now be causing harm when it didn't previously, just with the natural course of aging. And, in late life in particular, they found that substance use disorders have a higher risk of co-occurring mood and anxiety disorders, also PTSD, difficulties with sleep, especially with things like alcohol or benzodiazepines, cognitive impairment, also really common with alcohol and benzodiazepines, complications with the liver, and that may be from hepatitis if somebody was using IV drug use, or liver disease from chronic alcohol use, now having cirrhosis and needing a transplant or things like that. Mentioned sleep twice, I guess, because it's that important, but it can certainly have an impact on initiating sleep, quality of sleep, fragmented sleep, more drug interactions. A lot of patients are on medications that interact with alcohol, and this is more of an issue in later life as metabolism changes. And then there can be sometimes more severe withdrawal, even if they're not using necessarily much more of the substance or medication. And then just kind of taking a step back and looking at views, how does this older age group view addiction? And our general understanding is that kind of pre-World War II era, there was more of a moralistic attitude towards substance use. The population lived through the prohibition and temperance movement. There's more of kind of shame associated with substance use. And as a result, there might be more ambivalence towards seeking treatment because they might feel like they did something really wrong. And this is in comparison to the baby boomer population, where there may see substance use as being slightly more culturally acceptable. And as a result, they might be more willing to seek treatment. They might not bring it up unless we're screening or asking, but they might be a little bit more open to addressing it. And potential explanations for why this has been increasing. Why are we diagnosing substance use disorders more in late life? I think oftentimes when a question like this comes up, the initial answer is we're screening more, right? We've done better at acknowledging that this is a problem and we're screening more, but there's other issues for sure. I mean, there's an increased life expectancy in comparison to the past. There's also a heightened desire for personal gratification among many in the baby boomer population, right? This is maybe the era that kind of coined the phrase sex, drugs, and rock and roll. There's also that phrase, if you remember the 60s, you weren't there. So there was this kind of movement of self-love and maybe using psychedelics or cannabis or other things as a way to just kind of explore. And so it was definitely a bit more culturally acceptable during that time, but there may have been people that continued to use into late life, and as a result, we're now sort of making these diagnoses later in their life. A little bit on epidemiology, and a lot of this right now, at least, is a little bit kind of from a general aspect, but we will kind of go into specifics of certain substances through the presentation. But, for reasons I mentioned earlier, there's not a super clear incidence and prevalence that we've been able to find just because we know we're not screening enough. We know we're under-identifying, under-diagnosing, for sure, under-treating. And then there's not this consistency in terminology sometimes in the papers that we do have. Is alcohol dependence the same as an alcohol use disorder? When somebody mentions alcohol abuse, which is a word that was used a lot in some of these older studies, is that the same? Does that meet DSM-5 criteria for a substance use disorder? It's hard to say, and so it's just not very clear. But it also varies greatly based on substance, right? Cannabis is legal in several states now, and that kind of changes also the way that we screen and kind of obtain sort of data about that. I mentioned the lack of consensus around nomenclature. There's a lack of research on the topic. As I mentioned, a lot of the surveys sometimes include age groups up until 65 and then just kind of leave that age group out. Ageism, I mean, we might suspect that they're presenting a certain way, and that's just due to sometimes we call it normal aging. Like, of course, now you're having memory trouble, and we sort of blame it on that, and we don't take the time to screen or acknowledge that there could be other things that are playing a role in changing or having cognitive effects. And it might be difficult for family members or caregivers to accept that somebody in their family is struggling with this and to ask for help. This is just kind of an interesting little side note that I had found kind of recently. But the treatment episode data set, they call it the TEDS-A by SAMHSA. So any treatment facility that's received public funding is required to make this data available. And these are evaluations kind of between 1998 and 2018. So the percentage of older adults admissions increased from 2008 to 2018. This point, I think, was kind of one of the main reasons I thought it was interesting to include referrals to treatment facility. It was 42.30% by self and much less by the healthcare system. So it just kind of makes me wonder, could some of these things have been identified earlier through screening, whether it was in a general psychiatry practice, a general primary care practice, but it seems like we're still not doing a great job of identifying and screening people for treatment. They're kind of presenting on their own. And we know that it's there. I mean, heroin and methamphetamine surpassed alcohol as a primary reason for admission in these facilities. So it's a broad range of substances. And I've mentioned this a couple of times before, the DSM-5 Diagnostic and Statistical Manual. This is kind of the way that we make our diagnoses, not just for addiction, but for depression, anxiety, a broad range of mental health conditions. And they try their best to create a criteria that is standardized, specific, sensitive. But it's hard, everybody's different. People have different roles and things at different aspects of their life. And it's hard for us to use one set of 11 symptoms to diagnose something as complicated as addiction across all age groups. So while there might be some things that are similar, and I won't go down every single one of these, You'll notice that on the right, some of them just say same, like excessive time spent to obtain, use, or recover from the substance. There are some that are different. The first point we talked earlier about how there are physiologic changes in older adults, and the same amount of substance may now be causing impairment when it didn't previously. And as a result, if the person feels like I've been drinking the same amount forever, it's no different. I've never had problems before. They might really have difficulty realizing that their use is problematic. So it's hard for them to say they have a persistent desire, unsuccessful effort to cut down because they may not view it as a problem to begin with. They may have become a problem later in life. Role impairment, I think it's easy if this is somebody, maybe a 30-year-old at their job that's now not being able to fulfill their obligations, or now they're failing classes. But if this is somebody who's 81 years old and has been retired for 10 years, it's a little bit harder to kind of judge that aspect of it. And same thing with social roles. I mean, they may not have been as socially active at their age as they were when they were younger, and so that's difficult to use as a criteria. Um, so just a couple of differences. The screening tools that we'll kind of get into a little bit later try to take some of these into account as well. And I know the slide's a little bit busy. There's just a couple that I want to highlight. But this is talking about both risk factors and protective factors for substance use disorders in late life. So risk factors, that first bolded one, retirement that's not voluntary. When we think about the pandemic, right, there were a lot of people that maybe decided it was time to retire because there were lockdowns, and I've had a lot of patients that, were forced to switch to virtual and Zoom and Teams, and they're 76 years old, and now it feels like it's hard to keep up, and they've decided it's time for them to retire when maybe they weren't exactly ready to. That's been seen to be a risk factor for increasing substance use to a level that may be problematic. Of course, loss, in the older age group, they may be losing more family, spouse, friends, support system. Chronic pain, of course. I mean, we talk a lot about how opioid misuse for chronic pain for some people has developed into an opioid use disorder. Of course, availability. I mean, if you're living somewhere or if you're living with others that struggle with substance use disorders, it's going to be a risk factor. A family history tells us that there's a genetic component. A previous history, and that maybe this is a return to use. It may be more of a chronic course, and as a result, there might be more complications due to the duration of use. Um, and there's some protective factors. A lot of them have to do with increased support. Maybe married, having a spouse, having children that can watch after you, religious affiliations, a demonstrated history of resiliency. So there's been times where things went wrong in their life, but they were able to really respond well. Good social support, late life onset. So, if this is something that they didn't deal with their whole life and it's happening now as a result of maybe situational stressors and things, they have a better chance of obtaining recovery. They haven't shown to have this chronic course, or there may not be as strong of a genetic component. Cool. So that was a little bit of an overview. And I can't really see the chat too well right now while I'm presenting. So if there's anything, feel free to unmute. But I promise we can get to it at the end as well. But
Dr. Sanchez, we have a question
sure.
in chat
Yeah, no
or in the
problem.
Q&A.
Uh-huh.
I'm curious about the impact on effective expression. Is there any evidence that older adults with SUD experience symptomatic flat affect differently from those who are younger? Is this thought to be a co-occurring depression or part of the SUD manifestation?
That's a really great question. I don't know if I have the answer for it being different, specifically from younger adults. Something that I'm going to write down to look up, because that's such a great question. I will say that, some of the substances, especially some of the ones that bind to the GABA A receptor, like alcohol or benzodiazepines, it seems like, we always talk about acute withdrawal. With those two especially, we worry about somebody abruptly stopping after drinking a lot or after using a lot of something like Xanax or Klonopin or Ativan, because those are the two, especially the withdrawal can be severe enough that it can be life-threatening, right? So we spent so much time worrying about acute withdrawal, but now we've really identified this post-acute withdrawal syndrome. So this period outside of acute withdrawal that can last for weeks to months after. And one of the central sort of symptoms that I think have been identified with that is anhedonia, so an inability to sort of experience, joy or pleasure, which can look like depression, but it seems to be a component of this. But they've also made comments about this like sort of reduction in affective range, so not having that same ability to sort of express emotions and things. So that it makes me wonder a little bit about that, and that would be substance specific. So depending on which one, I think unfortunately a lot of times our patients that take medications or substances, I should say, that cause psychotic symptoms, like let's say somebody smoked methamphetamine and they experienced hallucinations, they sometimes come into our treatment centers and they're put on antipsychotics, and they stay on them longer than they're supposed to, unless they truly have an underlying history of a psychotic disorder. But it seems like those medications can also really reduce affect. So that's another just kind of thought. And some of these medications as well really have long-lasting effects on the brain, especially stimulants like methamphetamine that can also express um, or sort of show themselves as in a physical manifestation as reduced sort of range of affect. So I know that's kind of a lot all over the place, but it could be due to the substance itself. It could be due to medications to treat them at times, and it could be due to effects, long-lasting effects from chronic substance use. So I hope that's a little bit helpful. But I'm going to look into that some more because I think it's a really great question. Awesome. So kind of going specifically now into some of the substances, we'll talk about alcohol first. Uh, Alcohol is just it's ubiquitous, obviously. I think it's really difficult when you view it through the lens of somebody who's attempting to maintain their recovery, for example, it's Super Bowl weekend and every other commercial is, Miller Lite or Bud Light or whatever it may be. And it's just there. It's part of work culture. It's part of socializing. And as a result, we sometimes forget how harmful it can be. I think there's certain guidelines in Canada, even now suggesting that there's no safe amount of alcohol use, even minimal amounts, even what we've considered to be a standard drink, is harmful enough to cause long-term effects. And it's the most common substance that has been misused in older adults. And there's that terminology again, this is what's used a lot in some of the papers. And it's not necessarily clarifying that it's the most common substance use disorder. We don't know if it's actually alcohol use disorder, but we know that people that are older are using this more than what is recommended by the guidelines. There's an increase in alcohol consumption in those 50 years and older in comparison to younger age groups. Greater than 10% of adults age 65 and older binge drink or heavy drink, and we'll talk about what that means here in a second. 65% of people over the age of 65 and older reported high risk drinking at least weekly over the previous year. I think lately there's been this movement towards younger groups to really stay away from alcohol. It's become sort of a positive trend where I think a lot of younger individuals are drinking less and recognizing some of the harmful effects. But in this older age group, we haven't really seen that decline. If anything, we've seen an incline. Um, an estimated 4% of older adults struggle with alcohol use disorder, but again, we're under screening, under treating, so this number might be actually lower than the reality. And then I made this note here, one standard drink is 14 grams of alcohol, and you can see the image on the right. So 14 grams of alcohol is found in 12 fluid ounces of beer, 8 to 9 fluid ounces of malt liquor, 5 fluid ounces of wine, and 1.5 fluid ounces of liquor. And so it's always kind of an interesting exercise to talk to patients about, you have 3 drinks, but how much is that? How much are you actually putting in there? Because I think if you go out to a restaurant and you order a glass of wine, it's honestly often 8 ounces or more. There's 5 glasses of wine in a bottle of wine, a standard bottle of wine. So sometimes patients drink 2 of those. If they go out and have a margarita, it's probably not 1.5 fluid ounces. It might be more than that. But they might be drinking a handle, or a fifth of a gallon or more. And when you divide that by 1.5 fluid ounces, they might be having 40 standard drinks. They might be having a lot more than they realize. So, talking to them about that can be really helpful. And that kind of leads us into this slide. NIAAA has recommendations for the amount of alcohol use that we should have. The standard has been for females, it's 7 in a week or 1 in a day. And for males, it's been 14 in a week or 2 in a day. More than 3 standard drinks of alcohol is considered heavy drinking in late life. And I kind of jumped ahead there a little bit, so I want to take a step back. But so 7 a week in females, 14 a week in males. There's been some conflicting sort of recommendations and things, but for the most part, it's been recommended that in older adults, they follow the no more than 7 in a week, and really no more than 1 a day. But that's with the understanding that there may be some individuals that should stay away from alcohol use completely. If there's a history of dementia, if there's co-occurring treatment with opioids or something else, there might be a variety of reasons why we would say that 0 alcohol is probably the best choice. But heavy drinking has typically been considered more than 5 standard drinks in one sitting. They sometimes will say in 2 hours in younger adults. But for people above the age of 65, that's characterized as being more than 3 standard drinks. And again, if they've been drinking a certain amount their whole life and never caused problems, and they're still maybe having 10 standard drinks a day, they might not realize that they're consuming more than what's recommended, and that recommendation is there because we know that more than that is going to cause physical or mental harm. It could worsen their liver function. It could worsen their depression and anxiety, things like that. And then just some SAMHSA statistics here. Greater than 10%, of adults ages 65 and older were reported to have at least 1 binge drinking episode over the previous month. And then as mentioned below, there might be some conditions where even minimal alcohol use is not recommended. And just some important considerations. Young adults metabolize alcohol roughly 1 serving per hour. But this slows in older age, for the reasons we mentioned in the beginning: less lean body mass, less total body water. And so less amount of alcohol can increase the blood alcohol level higher than what they previously experienced, which can result in more harmful effects. And 78% of older adults in the US who drink alcohol are taking medications that interact with it. And oftentimes they don't know. I mean, I've unfortunately seen a fair bit of patients that are prescribed a benzodiazepine like Xanax, an opioid because they have chronic pain like oxycodone, and they're drinking 8 standard drinks a day. So taking 3 things that suppress your breathing, of course, as we get older, can be really, really dangerous. Just a quick look at early onset versus late onset. This is sort of a summary of what we discussed earlier, knowing that late onset sort of has better outcomes for a variety of reasons. But below the age of 60, this is unfortunately the majority, 67%. It's associated with poorer outcomes, more severe course, and this is primarily because of the chronicity of use. If they've been drinking most of their life, they've had more sort of damage to their body as a result. The frontal lobe of their brain may be more impacted, which makes it a little bit difficult to put the brakes on, to see consequences or problems with their use. And there's more likely to be a genetic component versus late onset, where if it's been a shorter course, there's less sort of long-term effects of their substance use. And it tends to be more often after the result of a traumatic event, like a loss or a stressful event. But they tend to respond much better, less likely to have that genetic component to their alcohol use disorder. And then just a couple of risk factors specific to alcohol use. I know we kind of spoke on it at a general level prior, but physical chronic pain, people oftentimes drink to reduce their pain. History of physical disabilities, if they're maybe having difficulty participating in more hobbies or things because of their physical disabilities. might be a higher risk of drinking, a change in living situation, maybe not being able to live in the same place that they grew up most of their life. Now they require more assistance, poor health status, chronic physical illness. From a mental health standpoint, an avoidant coping style, maybe it's a little bit easier to drink than it is to speak to a therapist or open up to somebody about what is, worsening their anxiety or low mood. A history of misusing alcohol in the past, a history of another substance use disorder, and then, of course, social factors like financial stressors, bereavement, unexpected or forced retirement, like we talked about before, lack of social support. I'm not sure how much it can be heard from here, but I apologize if there's a little bit of noise from we have a little bit of lawn work being done, so hopefully that's not too noisy. And then some more signs or symptoms of alcohol use disorder in late life. And again, understanding that it might not be easy for somebody to feel comfortable admitting that they're struggling with their alcohol use. These are some of the things that might be a little bit of a red flag, or at least put it on our radar. But worsening anxiety or depression, emotional lability. We know that alcohol impacts the frontal lobe, and people may be a little bit more emotionally labile when struggling with alcohol use. New social isolation, disorientation, memory loss, difficulties with decision making. Kind of back to that earlier point where we might blame this on older age. We have to do our due diligence and screen for things that could be impacting that, like alcohol. New onset seizures, if they never had any before. Poor hygiene, new falls, poor nutrition. We know alcohol impacts the absorption of a lot of things that are very important. So if labs come back abnormal, that could be a sign. New incontinence, new sleep problems, or maybe you prescribe a new medication and they have a much more severe response than you would anticipate. You might want to question sort of interactions or how they were being taken. And this summarizes a lot of the screening tools that we use for screening for alcohol use disorder. Depending on your facility, some of these may be built into templates and things that you use when you have an intake for a patient. CAGE has been around for a long time. Audit 5, very common. But I had never heard of MAST-G or the SMAST-G until I was kind of putting this presentation together. But I believe, as far as I know, that out of all of the screening tools that are available, this is the only one that has been created with older adults in mind. So as much as I wish that we could have a lot of time to talk about the various screening tools for older adults, this seems to be the only one. And I have a little bit of a summary of it because it can be fairly long, so I didn't want to take too much time going through every question of it. But it's 24 yes or no questions. And again, the name is the Michigan Alcohol Screening Test, geriatric. It incorporates changes in employment and social circumstances for somebody in late life. So kind of thinking back at that slide that had the DSM-5 criteria in comparison to how things might be different in older life, this kind of looked at that and tried to create a screening tool that would incorporate, the roles that somebody in older life may have, so that we don't miss it and we kind of pick up on those things that present differently than when they were younger. A score of 5 or more raises concern for alcohol use disorder and warrants further evaluation because, again, this is just screening. And so once we screen positive, we have to do a more in-depth interview. But there's been one study showed specificity of 65%, sensitivity of 93% for detecting problematic alcohol use. And there is a shortened, abbreviated version of it. It might be a little bit less sensitive and specific, but 10 yes or no questions, a little bit more helpful when time's limited, and 2 or more items as a yes represents alcohol misuse. So it's just a tool to kind of identify that somebody may be using more than what's recommended or may be causing problems in their life. But of course, this is going to be followed up by a more in-depth interview of understanding how much the person is drinking, how much it's impacting their life. And that could be a variety of ways. It could be worsening their depression, their anxiety. They could have cirrhosis and they're still drinking. But this is just kind of the start. And if you Google Michigan alcohol screening test, it'll pop up and you can see the full 24 question screening tool. So I've kind of printed it out to use in the clinic before. Cool. So I know we have a broad range of people within different aspects of the healthcare team in the audience, and so I'm not going to go into super specifics of dosages and things of these medications. I'm just going to speak on them at a more general level. But at the end, if there are specific questions about this, I'm happy to answer them. But alcohol withdrawal can be life-threatening. Um, it can cause seizures, it can cause arrhythmias, it can be very difficult for somebody who is older in age. Um, when you look at the Beers criteria, or we look at medications for things that we want to avoid in older age, benzodiazepines are on there, things like Ativan or Librium. But if somebody is at risk for experiencing alcohol withdrawal, we have to use these medications, and they're safe, especially in this context. And alcohol binds to a particular receptor in the brain, and so do these medications. And so, if somebody abruptly stops their alcohol use after, let's say, they were drinking 20 standard drinks a day, and they suddenly stop, and we know that they're at risk for this complicated withdrawal, we prescribe these medications that bind to the same receptors that alcohol do, and we slowly reduce them through their time in the hospital, so that their body can sort of detox, or we can manage their withdrawal to a level that's safe before they leave. Um, Ativan is a medication that we use very often because it isn't only metabolized by the liver. And so in people that have drank most of their life who may have cirrhosis, this might be a safer option. Librium is broken down by the liver and it lasts a little bit longer in the body. So if we're worried about somebody having interactions with other medications, or if they can't commit to being in the hospital as long, we might be a little bit more careful with that. But I want to stop for a second because I saw that somebody raised their hand. It disappeared, but it might have been an accident. Okay. Maybe it was an accident. If so, if not, feel free to let me know whenever. I wanted to make a quick note on the bottom, and this is sort of an anecdotal case, something that happened in one of our hospitals one time. But I think we've gotten so used to giving these medications for withdrawal that sometimes it's just part of the protocol when people come in. But there's been times where people come in, they're still intoxicated on alcohol, they may be agitated or aggressive, and they give them a medication, oftentimes a combination of medications for sedation. It usually involves a medication called Haldol, Ativan, and Benadryl to help people feel more calm when they're acutely agitated from alcohol use. But in older age, that combination of the Ativan for agitation with the alcohol that's still in their system can be enough that it can be very dangerous. We've seen cases where people were intubated because they were given this combination of medications for agitation, and people didn't realize that the Ativan in it had a synergistic effect with the alcohol that was still in their system, and they had a really adverse reaction. So we have to be really careful on not giving these while somebody's acutely intoxicated, but we can't be scared to give it to them in withdrawal just because they're older. We don't want somebody in older age to have a seizure. We want to treat it appropriately. And you can, of course, always use lower doses and kind of increase as needed. Naltrexone. So these first two, we're really talking about somebody who comes in and we're worried about them having acute withdrawal. They need medications now so that they don't have any harmful medical complications from their discontinuation of alcohol use. But let's say that they've gotten past this point. Now they're not in any danger of acute withdrawal, but they've left the hospital and they know that alcohol is a problem for them. They know they shouldn't drink, but they've been drinking for so long, and now they're having cravings, and they really want to go back to use, and they're having anxiety, maybe trouble sleeping, and the only thing that's gonna they feel like it's gonna make them feel better is returning to alcohol use. So we have three medications that we use to treat alcohol cravings, and this is the first one, naltrexone. It acts as an anti-craving, anti-reinforcing medication. We know that alcohol, through some downstream effects, increases endogenous opioids in the brain. So that's why it's sort of reinforcing and euphoric. And so when we give a medication that reduces this, it reduces the desire to drink. And this has been shown in studies to reduce the return to use. If somebody continues to drink, they're not going to feel ill because they drink while taking the medication. but they seem to have fewer heavy drinking days, which for an older adult, that's fewer days drinking 3 or more. And for somebody younger, 5 or more. It's metabolized by the liver. And so we always check their liver to make sure it's okay, especially if somebody's been drinking for a long time. It seems a little counterintuitive that we're giving them a medication that's also broken down by the liver. But if they're not acutely hepatotoxic, so not having a current liver injury, it's safe to take. And again, it's going to reduce cravings, reduce heavy drinking if they continue to drink. And it also is available in an injectable form. But we'll talk about that here in a little bit when we talk about opioids. So that was one of them, naltrexone. And again, this is when they're beyond the withdrawal window, but we're more so trying to help them from returning to use or returning to problematic use. Acamprosate is another medication, similarly helps to reduce cravings. The interesting thing about this one is it's not broken down by the liver, it's broken down by the kidneys. So if somebody's been drinking most of their life and they have liver complications, this is something that will be safe for them to take, assuming that they don't have severe kidney disease. So the dosing is the same as younger adults. We just want to avoid it if their kidney function is impacted. Very interesting, the dosage. If you've used it before, you know that it comes in 333 milligram tablets, but the recommended dosage for reducing alcohol cravings is 666 milligrams 3 times a day. And so the reason I bring that up is it can be hard for people to want to take 2 tablets 3 times a day every day. So in comparison to naltrexone, that was just once a day. So just something to keep in mind. One thing I didn't mention about naltrexone also is that this blocks the opioid receptor. So if this is an older adult who is on opioid medications for chronic pain, they wouldn't be able to take that opioid medication for at least 7 to 14 days before starting this medication. Could put them into opioid withdrawal. And so that might be another reason to consider acamprosate over naltrexone, knowing that a lot of our patients that are older have chronic pain. And so they may not be able to take naltrexone. Lastly, disulfiram medication's been around a long time. This is the one that a lot of patients come in and will say, is this going to make me sick when I drink? Referring to naltrexone or acamprosate because they've heard a lot about this one. But disulfiram is the medication that blocks a portion of the metabolism of alcohol, so that there is a buildup of one of the toxic metabolites, which then causes side effects. And so it's kind of like a psychological barrier. People know that if they drink, they're going to feel really sick. And so they take the medication to prevent themselves from returning to use. I don't prescribe this very often unless somebody really comes in and asks for it and they feel like that's going to be the thing that they need. Just because the reaction can be so severe. I mean, somebody in older age, if they accidentally drank or they use hand sanitizer, hairspray, something that might have had alcohol in it that set off a reaction, the tachycardia and flushing and nausea and vomiting can be really severe and can be kind of dangerous for them. So you want to avoid it in somebody with cognitive impairment that may forget and maybe return to drinking and have this reaction. It can be pretty hard on your heart if you have this reaction. So we avoid it in somebody with cardiac disease, and we also avoid it in severe liver disease. One small side note, there is a sort of different reaction that occurs in the body that can increase dopamine with this medication. So if somebody has a history of psychosis, rarely, but potentially possible, disulfiram has sometimes caused or worsened psychosis. I think I heard a mic. Okay, just want to make sure there wasn't a question. All right, I know that was a lot on alcohol. That's probably the most comprehensive one. The ones that are going to follow here are a little bit briefer. But nicotine, just kind of going in order, alcohol is still the most problematic substance in older age. But tobacco use is second. We know this has been a problem among a lot of different age groups, but very common in those above the age of 65. Different statistics we have 14.1 here, but above the age of 65, but it may be 30% in those between 50 and 64. There's approximately 300,000 deaths related to smoking a year in those above the age of 65. And it's commonly overlooked because people aren't necessarily presenting to the ER for nicotine withdrawal or nicotine intoxication causing hallucinations or anything like that. And so kind of flies under the radar. I think historically rehabs have also allowed smoking to be done on campuses. People will sometimes achieve recovery from opioid use disorder, but they feel like they have to hold on to the tobacco, that it's the one thing that they have left. So it can be a really tricky substance to tackle. And there's also an association with an increased suicide risk as well. And so when screening for tobacco use, we always want to make sure that we're screening for depression symptoms and suicidal ideation. So we know it's a problem. I think everybody here knows that tobacco isn't good for you and that stopping it can have immediate positive effects. But how can we tackle this in older adults? A big portion of this is going to be the psychosocial component, motivational interviewing, a brief intervention, but just briefly tackling some of the pharmacologic things we have. We have the gum, the patch. These things work. They work really well, but they have to be used correctly. And sometimes people chew the gum and they just swallow their saliva. And I'm always surprised at how many times I have the talk with the patient and they never realize that you're supposed to chew the gum, chew it till it tingles, park it between your cheek and your gums, let the nicotine be absorbed by the mucosa, the lining of your cheek. When you don't feel the tingling anymore, you chew it again until you do, and then you park it again. That's the only way that you're really going to get this nicotine absorbed, which can reduce some of the cravings that you have for tobacco. If you're not doing that, you're not really going to get a lot of the benefits from it. So that's always important. But on that note, some of our folks that are a little bit older may have poor dentition. They may have TMJ or clicking, and they may have dental appliances. So it may be a little bit trickier to use the gum. And as a result, we also have the lozenge, so they can try a lozenge instead or the patch. But this is great for breakthrough cravings. So totally great to use. The patch, we kind of look at it sometimes as the patch working in the background. And even if you have the patch on, if you experience that strong craving, then you can use the gum. Safe to take the two together. There's no specific changes for older adults, but it can cause nightmares when people sleep with it on. So we ask if that does happen, they just take it off before bed. Um, and It's almost like the way that we look at insulin, right? Like the basal bolus. Sometimes people take a dose that lasts them the whole day, which can kind of be looked at as a patch. But then there's the doses that you take before meals, which can kind of be looked at as a gum. So it's safe to take the two. There's some thought that in folks who have cardiac disease, that it can increase the risks of an MI. The nicotine can be sort of stimulating, cause constriction. Um, but it does it much less so than nicotine from tobacco, from a cigarette. So if they're able to stop tobacco as a result of the gum or patch use, that's going to be a net positive. If we undertreat and we're scared to use the gum or the patch for that risk, but they're still smoking, that's going to be a much higher risk. So it's just a discussion you have to have with them. And then just briefly, they actually make inhalers. I didn't know this until last year, but you can inhale. There's also like the nasal spray. And so if for some reason they don't want to choose something, those are some considerations. You want to be careful with some of the sprays if they have respiratory diseases. And then the lozenges are available if they have dental appliances and don't want to use the gum, which for some people has been really hard on their teeth. Um, and then there's Chantix, right? Is the one you might have seen the cold turkey commercials online. Varenicline is the generic name for it. It has been proven to be very effective. It was briefly taken off of a lot of formularies in hospitals because there was something that came out about some risks associated with it. But through studies and other formulations, it's available in most places again. But it can be really effective for reducing tobacco cravings. Um, and the only thing that's been reported to keep an eye on is for some people it's caused worsened mood, more depression. There's been some report of suicidal ideation. And so if you started somebody on this medication with an underlying history of depression, you'd want to just kind of check in on their mood after. And then lastly, bupropion. So it's a medication that's an antidepressant that's also approved for smoking cessation. So if this is somebody who is struggling with depression and tobacco use, it might be one medication that can help with the two. And for some people, it's worked incredibly well. For others, they do this and they need the patch or the gum, and that's okay. Okay. So we talked about alcohol, we talked about tobacco, the kind of two bigger ones. Now we're going to go into some of the other substances, starting off with the opioids here. Chronic pain is incredibly common in older age. At least 4 to 9% of older adults are prescribed opioids for pain. Multimodal treatment options aren't always available. So if you go to some big institutions, sometimes you'll see they have a pain psychologist. They have acupuncture, they have physical therapy, occupational therapy, psychiatrists, internal medicine, and they have this whole multidisciplinary team that really tackles chronic pain. But that's not always available, which can make things a little bit tricky. There's a risk of serious side effects with age, particularly when opioids are combined with other downers like alcohol or benzos. You can really slow down breathing, which can be dangerous. This 2013, 2015, just kind of an interesting note, there was a significant increase in the diagnosis of opiate use disorders. And older adults may be less inclined to accept an OUD diagnosis when they have pain. So their pain is very real and they need to hear that it's very real. But that discussion about how, while their pain is very real, this might not be the best choice for them long term is a very important one. Going back to this point that maybe they took this for most of their life, but now they're at an age where the medication's impacting them in a way that it didn't. Now they're having falls, now they're having cognitive impairment. Maybe they're still using the substance at the amount that it's prescribed and things, but they're having negative effects and having difficulty stopping it. That can be a really tough conversation. But some common characteristics for older adults with opioid use disorder, multiple medical comorbidities. I know we mentioned chronic pain multiple times, very important. Co-occurring mood and anxiety disorders, so MDD, GAD, post-traumatic stress disorder. We know that opioids can also treat mental anguish or pain. And so it's not a surprise that sometimes when people have co-occurring anxiety or mood, that this medication can help really reduce that as well. Of course, a history of misuse, maybe multiple physicians who are prescribing medications, having family members who kind of rationalize or deny their use because it's also difficult for them to see their loved one in pain. Another sign can be emergency room visits for sedation. And there's been some statistics to show that it may be more common in older age in women than men. And just a quick note on this, I think I'm sure many of you have heard conversations about the waves of the opioid crisis, right? And I think it's important to just note that many of our older patients were prescribed opioids for chronic pain earlier in their life, told that it was safe, told that it wasn't addictive. Were put on very high doses of these medications. And then at a certain point, when some of the dangers and risks were discussed, these medications were pooled, and oftentimes they were pooled without any other sort of plan in place. And so people may have turned to buying them from other sources, to using other things like heroin or fentanyl as a way to deal with some of the discontinuation syndrome or opioid withdrawal that they've experienced. And that in and of itself sort of progressed to an opioid use disorder. So it's really an important component to understand and empathize with their very real pain that they've experienced while addressing this in the safest way. I mentioned this earlier, there's a variety of screening tools for opioid misuse, opioid use disorder, but none of these are specific for older adults. The bottom one, the BRIAS criteria medication list for potentially inappropriate medications. This long list of things that we should probably avoid in older adults, but it's not for opioid use disorders, just for medications that could have harmful consequences. So just a quick note on that, it was updated in 2019 with the recommendation to avoid opioids for chronic pain. It should be reserved for the management of severe acute pain. And a review of opioid-related deaths between 2001 and 2016 found that older adults constituted the largest relative increase during this period. So we know it's a 754% increase between 55 and 64. These are really big numbers of people that were being very severely hurt by this. And sometimes I tell I there's a really great podcast, and I wish I could remember the name, but it was with a psychologist that dealt with chronic pain. And she talked about this story where somebody was on a work site and they stepped on a nail and they saw the nail go through their boot. And they could see the nail sticking out of it. So they were in tons of pain. They're screaming. They were brought into the emergency room. They carefully removed the boot and found that it had gone between their toes. And so it hadn't actually punctured the skin or caused any damage. But that was used to illustrate the point that while, of course, local tissue damage is a source of pain, there's also a part of our brain that sort of interprets and takes in stimuli and then produces a signal for pain on what it is sort of basing that it should be. And so as much as we can empathize with people having chronic pain from osteoarthritis, different things, we have to at least acknowledge the mental aspect of it, which is very real, but also needs to be addressed in this multimodal way. So just wanted to mention that. And then briefly, again, I'm not going to go into the super specifics of this, but for opioid use disorder, we have methadone, Suboxone, and naltrexone that are approved. These are life-saving medications that work incredibly well, and they can be used in older adults. Methadone has been around longer than Suboxone, at least for this indication for sure, at least since the 1970s. It's a medication that binds to the mu opioid receptor, and it binds and it fully stimulates it. And so if somebody's in opioid withdrawal, it binds to that same receptor and it helps provide some relief from cravings and prevent withdrawal symptoms. Uh, there's a thought that it is less associated with respiratory depression and some of the risks when compared to things like fentanyl or heroin. But it's still what we call a full agonist. It still fully binds to the receptor. And the bigger dose you get, the more effect you get and the more side effects you can get. It can have some cardiac effects, so we have to get an EKG just to make sure that somebody's safe to take these medications, especially at higher doses. And people can overdose, especially when combining with other medications. So in the fentanyl era, it's felt that for some people that Suboxone has not been enough, and they needed something that was a little bit stronger, where they could go up to higher doses. And this is okay to use in older adults. We just want to make sure that we increase the dose and sort of an appropriate, maybe slower rate to make sure that we're not causing any bad side effects or slowing down their breathing. But we also don't want to undertreat, right? We give too low dose of methadone, somebody leaves the clinic, they go to use something else because they don't feel like their withdrawal is adequately treated, and then they're exposed to something and maybe overdose and lose their life. So we don't want to be too cautious because they're older. We want to still use the medication at a rate, understanding that they have built a tolerance through the years and they will still be able to tolerate maybe even higher doses of methadone. And one other quick note is that the rules and regulations surrounding methadone have not been updated for a long time. There were some slight updates through the pandemic, but for the most part, a lot of facilities still require that you come in for daily dosing. And so if we look at an older adult that may not have as much social support, that may not drive anymore, that is now being told that they have to come in every single day to get the methadone from the window to take their individual dose for months before they'll be considered for weekly doses. That can be really a lot to ask for somebody. So it's just something to take into consideration. Suboxone or buprenorphine and naloxone, the combination together is often referred to as the brand name Suboxone. Also binds to the same receptor that methadone did. It helps prevent withdrawal from opioids and it helps reduce cravings so that people don't return to opioid use. People get stuck in this cycle where they keep using because they feel so sick when they stop. So these two medications can provide relief so that they don't experience withdrawal anymore and they can kind of get their life back and do the things that they want to do. The really kind of beautiful thing about buprenorphine is that at higher doses, it has a ceiling effect, really beyond 28 to 32 milligrams. There's no added benefits and there's no added side effects. So if somebody tried to take more, it wouldn't increase their risk of overdose. So it's just kind of the overall safer option. I know some institutions have recommended using buprenorphine for chronic pain versus something like oxycodone or Percocet or Vicodin, just understanding that this is a much safer overall option. It's not really altered by renal, like kidney or liver function. There's very little chance of misusing it. It's very effective. 16 to 24 milligrams of Suboxone has as good outcomes as 60 to 80 milligrams of methadone. So it works very well. And there's a lot more flexibility. We might want to see people weekly initially, but pretty quickly, if they have good social support, you can get somebody that's doing well to be given refills every month or every couple weeks. Maybe you check in with them by videos in between. But this can be an option for somebody that can't come to the clinic every single day. And then one study down here just mentioning low dose buprenorphine in older adults with depression found medication to be very well tolerated and safe. And then lastly, we talked about naltrexone for alcohol cravings. It's approved under the name Vivitrol as an injection for opioid use disorder. And so it's a once every 28 days injection, 380 milligrams. A lot of patients really like it because they don't have to worry about taking something every day. It's just one shot once a month. Works very well. But as mentioned before, if somebody's on opioids, you have to give it some time before giving the shot. If they're going to go into surgery or have some procedures where they may require opioid medication, then you might want to kind of hold off on it, maybe switch to the oral medication until leading up to the surgery. But it's essentially just a shot version of what we described before, approved for opioid use disorder. Okay, and we're getting closer to the end here, and I want to make sure I leave time for questions and things too, but I'm just going to touch on a few things briefly. Sedative hypnotics, things like benzodiazepines, the drugs like sleeping medications like Ambien, we try to avoid in older age just because we know that there's an increased risk for falls, impact on memory. There's been more motor vehicle accidents. And again, they may have been prescribed this earlier in their life and it worked great for their anxiety, but now they're older and now it's impacting them in a way that they didn't have before, and they might have a lot of trouble coming off of the medication. So it's really important to have that discussion about risks and benefits and how this is typically only approved for short-term anxiety. It should not be used chronically because of the risks associated with it. But as mentioned before, we just don't have a lot of data right now to suggest how high this rate of misuse or benzodiazepine use disorder, how high that might be in older age. Cannabis use, this is also very difficult to give adequate or up-to-date statistics on, just with the state of legalization and how much it's changed. I was in Connecticut for a year where it was legal, and it was very different than how it's treated where I currently am in Texas. But we know that there are some risks associated with cannabis use: cognitive impairment, psychomotor slowing. There can be increased risks of heart attacks, strokes. If somebody already has an underlying history of psychosis, that can increase that risk. There's an association with suicidal ideation. And nowadays, we know that THC is much higher than it was in what people were used to earlier in their life. And so it might not be the same cannabis that they were smoking before. And so it can be more problematic, while simultaneously sort of acknowledging that there are some indications like increasing appetite in patients who have cancer, things like that. And again, I know it's become a theme, but no specific screening tool for cannabis use, unfortunately. So it's a lot of just taking the history, understanding how it impacts their overall health and mental health. But this is just an overall kind of screening tool that we use across all age groups. Just kind of assessing how often are you smoking cannabis, how many hours were you sort of under the influence of cannabis use. It helps us get some understanding of how it's impacting their life. And then, we mentioned this a couple times. This is not really specific to any one substance, but misuse, using a substance could be a prescription for a reason other than indicated. Some people misuse Tylenol. They take way more than they're supposed to. They misuse ibuprofen. But misuse is pretty common, the most common, with substances that impact sleep, pain, and anxiety. As mentioned before, for benzos and cannabis, we just don't know the exact rate right now because we're not really screening for it the way that we should. We know that older adults, as we talked about, have a higher rate of chronic pain, so opioid misuse is a concern, and it's important for us to understand that they're just trying to get some relief. So pain relievers seem to be the most misused medication, but there's no validated screening to assess for over-the-counter medication misuse in older adults. And we touched on this a little bit already, but things like stimulants, cocaine, inhalants, hallucinogens seem to be less common than tobacco and alcohol. But as we mentioned earlier, kind of at the beginning of the presentation, it seems that people are presenting to some of these facilities for treatment are showing an increased rate of admissions for opioid and stimulant use. So it's something to keep an eye on for sure. And this is the section that I'm going to kind of finish up on. Just psychosocial treatments and interventions. There's just a couple of really quick important points. I spent time talking about medications. Things can be really helpful for older adults, but psychosocial interventions are really the cornerstone for all substance use disorders. One point that I just want to really drive home that I hope is remembered is that we hope that these are age specific. It's really hard for older adults to sometimes attend AA or similar groups where they feel like they're hearing about problems from people that are maybe in their early 20s or figuring out life very early in their life. There's a lot better retention and benefit from groups and resources that are specific for their age group and that are going to cover topics like loss or retirement or during the pandemic, a lot of older adults felt like they were being left behind because of this sort of surge in technology and video use. And so groups that specifically cover this topic and make them feel like they're not alone are going to be the most beneficial. Within that setting, you can screen for cognitive changes, other issues that may be impacting later life. And you could also have brief interventions. So you can talk to somebody about their current substance use and how that relates to the current recommendations. Is it higher? Is it at risk? Is it not recommended whatsoever because of co-occurring conditions that they may have? And these interventions have been shown to be beneficial through a variety of different sort of programs. We'll kind of briefly talk about one here in a second. And we could spend a whole hour on SBIRT, screening, brief intervention and treatment. But this is just to say that we need to screen. And although we don't have some stuff that are specific for late life, just asking the questions, if you ask somebody if they smoke tobacco and they say yes, they're screen positive. That's the only screening question because we know that no amount of tobacco use is safe. But asking about alcohol use, opioid use, how it impacts their life, any methamphetamine use, any cocaine use, all those things, that would categorize or I guess qualify as being screening positive. And then, as mentioned, a brief intervention would be making them aware of how that relates to what recommendations are and how that might be impacting their overall medical health. That can sometimes be in things like workbooks and things like that, but motivational interviewing, empathic listening, supportive psychotherapy, understanding where they're coming from and how they use their substance use, all that in and of itself can be therapeutic for a patient. But if somebody needs it, if they're really having difficulty stopping or cutting down, then they might need to be referred to an addiction psychiatrist, to a rehab program, and ideally one that might have geriatric resources or resources specific for late life. Briefly, this is one I just found online while kind of researching. It's called the Florida Bright Program, so brief intervention and treatment for elders. And it did exactly what we just talked about. There wasn't anything super fancy. It was screening, patients were screened positive in the clinic for substance use. They were given educational materials. Went through motivational interviewing. So they had open-ended questions, they had affirmations, they had sort of empathic listening, reflection, summarizations. They had this sort of aspect to really help them understand why they may want to change the way that they're using substances. And then they were given age-appropriate information for coping mechanisms, prevention. Of course, we want things to be in larger text for them, easier to read and see. And just that in and of itself lowered that MAS-G scores, the ones that we talked about earlier, the only screening tool that was specific for older adults. So that just the education, just the motivational interviewing, just the information about coping mechanisms helped reduce their overall scores for this, which was great. And there was a 30% reduction, or at least had fewer flags for prescription misuse. Also a large decrease in depression and suicide risk. So again, this was just using empathic listening in these tools. This isn't even kind of including some of the medications that can be really helpful. We want to match treatment to the individual's needs. So having things during daytime hours, assist with transportation if needed. If they need in-home or telehealth services, helping them set that up. If they go to a rehab program, we don't want them to go somewhere where they have to take the stairs every day or where it's very dimly lit. We want something that can accommodate for vision and hearing impairment. So as kind of mentioned previously, if we're given educational materials for them, we want them to have things at a font that is easy for them to read or see. And, presentations, if they're going to receive educational materials, we want it to be at a slower pace. We want to repeat some of the important points, and really kind of help drive some of these things home. I mentioned this earlier, but some of the topics for group therapy, if available, should cover aspects that may be really important in this stage of life, like grief or loss, social pressure, life stages or changes, and role transitions. Another topic that I wish we had more and more time to talk about, but if we can pull aspects from their culture, even better. I am Mexican American, and I grew up with my entire family coming to appointments. If grandma had an appointment, mom came, I came, everybody came. And that might mean a lot to somebody. So understanding aspects of their culture that may play a role in them having successful treatment will really help. And if you can respect that, it might build a stronger therapeutic alliance and lead to greater retention and treatment. So that's really important. And this is sort of within the same realm, but you want to involve caregiver and family if you can, just like we just mentioned. Oftentimes, somebody in older age has many different members of their healthcare team. And so if we can coordinate across clinicians to have a general understanding of the medications that are being prescribed, what the treatment plan is, even better. And MI, motivational interviewing, can also be a talk on its own, but that can be really helpful for this age group. And this is across the entire realm of mental health in general, but we know that there are disparities, and especially there's certain age groups, genders, ethnic and racial groups that aren't getting the same level of treatment that they need. And this is the same for addiction as well. And so we have to understand that aspect and how it may also lead to them maybe being more reluctant to seek treatment. I wish I had more time to talk about this, but incredibly important. And then this is just a summary. We talked about this in the beginning, but some of the barriers might be stereotypes about addiction in older adults, and this is barriers to receiving treatment, misattributing symptoms to age, blaming their cognitive impairment on their current age and not alcohol or other substances. It might be a lack of training and just screening, brief interventions, MI, what available treatments are there in your facility. But I know we kind of touched on most of these. So just a brief kind of summary. I know it was a lot of information, so I really appreciate you guys listening in on this, but we want to be supportive. We want to be non-confrontational. We want to just understand. We want to be flexible. We don't want to put more barriers to treatment. We want to sort of make it as available as possible. We want to be culturally responsive, and we want to adapt any of the treatment plan to this individual's physical or cognitive needs. So that's it for me. Yeah, these are all the references associated with the presentation. But thank you. So.
Great. Thank you, Dr. Sanchez. So I have one question that came to me. So I'm going to go
Sure.
ahead and get us started with some questions. So unfortunately, addiction psychiatrists are hard to come by here in Kentucky. So if we're thinking about referring a patient we're going to use an example of opioid use disorder to traditional OBOT treatment here, which is office-based opioid treatment. It's very encompassed in meeting with, a clinician, a case manager, peer support. for
Mhm.
this age group, that could be individuals significantly younger than the patient, right? And so it's really hard to have that connection. Can we talk a little bit about the possibility of like an internal medicine treating, opioid use disorder in that clinical setting opposed referring out to an OBOT?
Yeah, that's a great question. And I'm really happy that it seems over the last couple of years that there's been a big push to train multiple specialties on addressing addiction. And internal medicine has become a really, really big component of that. When I did my fellowship, we were actually mixed with addiction medicine and addiction psych. And so half of our group was internal medicine and half was psychiatry. But with all that being said, more recently, they did away with what they used to call the X waiver for Suboxone. Um, and so now anybody can prescribe Suboxone. And if you have to have a DEA license to practice medicine, and when you renew your DEA license, you have to go through this training for it. And so theoretically, anybody who's really practicing has the ability to prescribe Suboxone. It gets a little bit more complicated with methadone. But even the medications for alcohol use disorder and other ones, they can be prescribed by internal medicine. Um, it may be dependent on how comfortable somebody is. I think that unfortunately there's been this sentiment for a while where people that didn't want to specialize in addiction treatment felt like if they started somebody on Suboxone, that they were just going to have that patient forever and that they were going to have to keep refilling Suboxone. And it's a really unfortunate way of looking at it because it's such a great medication and it's life-saving. And if we can start somebody on it sooner and prevent them from using what we know is a really unsafe drug supply, we can save their life. So I know that's kind of a long-winded answer, but I agree. I do think that internal medicine, family medicine, even geriatrics can prescribe Suboxone. Sometimes it just takes a little bit of our advocacy and really kind of pushing them to feel comfortable doing it, understanding that it can be really helpful for somebody.
Dr. Sanchez, I have a couple of questions that came to me as well.
Uh-huh.
The first one is, why do you think there is a lack of research and programming for older adults, given the statistics such as the double since 2002?
Yeah, great question. It seems to be the case along a lot of things as well, not just addiction, that we seem to leave out older folks, which is a bummer. And I think I wish I knew for sure the answer. One thing that comes to mind is I still feel that a lot of people do not realize how effective our medications can be for addiction. I think for a long time, this felt like it was just a chronic disease that, if you were diagnosed with alcohol use disorder in your 20s and it was very severe, it was just something that you were going to have for the rest of your life, and there's not anything you can do. And I think especially when somebody sees older adults, they started to feel like, well, they're 70 and they're still drinking. There's nothing that we are going to be able to do for them now. And it's just not the case. I mean, I think these medications can be really effective and they can be effective in older age as well. There's never a time in their life where suddenly there is no answer, or no choices for them. Um, so some of it, I think, is education. And I wish I could remember the exact percentage, but there's a statistic about how little education around addiction there is in medical school. And when I was in medical school, I think out of the 4 years, I got 1 week of addiction education. And so it really was in residency, knowing that I wanted to do this, that I got a lot of it. And then, of course, I did a fellowship where that was just dedicated to addiction. So I think some of it is, to summarize, not realizing the effective, how much the medications that we have available are effective, including for older age, and also not realizing that just because somebody's older doesn't mean that they don't have a chance at recovery now. They certainly do. And I feel optimistic that I think we're starting to realize this more. And I think some of the organizations like the American Academy of Geriatric Psychiatry are recognizing that this is going to be an issue with the baby boomer population getting older. And so there's a lot more resources going into studies and research now. And so my hope is that in the next couple of years, hopefully we'll have more guidelines, data, evidence, things like that. But I hope that was helpful.
Yes, thank you. The last one I had was, what do you think are the differences regarding the treatment efficacy between community treatment and in a long-term care setting?
Ooh. Oh, that's a great question. I mean, I think in the older age group, especially when I work for the county hospital system, and so my answers always kind of come from that lens of seeing a lot of people that don't have a lot of social support. And so the thought of them being in a long-term facility where they do have somebody that's kind of ensuring that they're taking their medications, monitoring for any adverse effects or side effects, that just feels like it would be a lot more effective for somebody in this age group. Um, but that's, with the assumption that maybe they don't have a lot of social support. Because if they were at home and they did have a very supportive family that drive them to their appointments, to check on them often, it might be equally as efficacious. But it's hard. In the most ideal setting, we would have a group where they had age specific groups. They were in a long-term facility where they went to groups with other folks. They had social interactions like bingo or other things with people their age. And you don't always get those things when you're just home. So uh, while I don't have the exact answer, I imagine that kind of a long-term care facility is probably going to be more beneficial for a variety of reasons.
Thank
And
you so
Dr. San-
much.
I have a question for you as well, Dr. Sanchez, that came to me. In the area of smoking cessation, we have seen an increase in the nicotine pouches being used here in Kentucky.
Yeah.
There's not been a whole lot of research on those. Are we starting to see some of that come in? And is that a safe alternative to offer to our older population?
Oh, that's a really great question. And it's something I've been meaning, it's on my list of things that I've been meaning to really read a lot more about because I think we're seeing it a lot more in Texas too. And I've noticed that it seems to be really popular on social media. And, um, sometimes you see like country singers that use them on stage and things like that, or Zen or whatever it may be. And so I think a lot of people are being influenced to use that, and they feel like it's cleaner, that it's just nicotine without all the additives, at least not as much as a cigarette. So I don't think that we have, as far as I know, any real strong evidence right now to suggest that it's been super harmful. But I can't say that that's going to be the case forever. I imagine now that it's really popular and that there's a lot of use, that we'll have more sort of data about potential adverse effects as time goes on. On the surface, it sounds like a better option. I mean, it's not being smoked. You don't have like the polycyclic hydrocarbons that are known to be cancer causing and things. Um, but I can't say for certainty that it's going to be 100% safe, but it seems to be at least a safer alternative in comparison to cigarettes.
I think we have time for one more question. Do you have another question, Amber? There's one in
That's the only one I was
chat.
going to mention. The one
Okay,
in
go
the chat.
ahead. Go ahead.
We have one in the chat that says, I have clients who are older who have discovered that they have ADHD and have a long history of meth use. They were self-medicating with that stimulant in order to actually function better. Are psychiatrists becoming more understanding of this? I know in the past, providers will not prescribe a stimulant if they have addiction in their background.
Great question. Yeah, you're right. I mean, I think I've done it. I've prescribed Adderall or Vyvanse to patients that I truly believe have a childhood history of ADHD that is currently impacting uh, their current ability to do the things that they need to do now. Um, Understanding that they were probably turning to the methamphetamine as a result of it being untreated. And I think we've just had such a paternalistic view towards some of these medications at times that we withhold them and then don't realize how sometimes it's counterintuitive and it makes things worse. Of course, it sometimes makes us a little bit nervous that it could be misused, but when I talk to people about it and I really feel that they have a true history of ADHD and we start something like Vyvanse, I just let them know, we can't do early refills if there's more used than what was prescribed. I can't refill it early. We're going to do urine drug tests. We do urine drug tests that have confirmation tests that can separate something like Adderall from methamphetamine. So it really tells us the specific amphetamines in it. And I want them to know that we're doing it just to track their treatment, and we want them to be in recovery. So similar to when people are on opioid withdrawals, we give them a safer opioid like Suboxone or methadone. we don't have a replacement therapy for methamphetamine, but methamphetamine is a huge problem. And so they've started to look at Vyvanse or Adderall or other stimulants as almost like a replacement therapy. And it has some mixed data. But I do think that if the goal is recovery, and they have a history of ADHD, that there's nothing wrong with prescribing a stimulant. Of course, if it's misused, it kind of becomes a bigger conversation of how we can tackle that. But yeah, and just one other note, I think paradoxically, people who are on stimulants often feel more calm. They feel like their mind isn't racing. Now it's at a level where they feel like they can express themselves. And so if somebody's using methamphetamine and they're not feeling up, they're feeling down, that can kind of tell us that they're probably self-treating their own ADHD, and we should do a good job of treating it. So I hope that's helpful. There was, I'll just mention briefly, I know there was a quick question on how long would you keep someone on Valium that was getting off of alcohol? It's a really good question. For some people, they can experience post-acute withdrawal syndrome from alcohol for up to a year, but we don't typically keep them on a benzodiazepine like Valium that whole time. We might help them slowly taper off of alcohol over the course of 2 weeks, 3 weeks. And then we use other medications like gabapentin or other things to really help with the distress associated with stopping both the Valium and the alcohol. But it really depends. If they've been on Valium for a very long time, it might take a very slow taper, sometimes even over the course of months, for them to feel comfortable and to avoid them feeling bad enough that they would return to alcohol use.
We have one more question in the chat if you want to answer that real quick. Can you prescribe Suboxone and Adderall at the same time? Are there any known interactions?
Great question. We can. Yeah, we can. I mean, different mechanisms of action. No clear interactions that I'm aware of. It's safe. And if somebody has a diagnosed history of ADHD and opioid use disorder, I completely understand where this question is coming from, because I think prescribers get really nervous about prescribing 2 controlled substances to somebody. And there's so much sort of, I think, I don't know, we feel nervous about it, and it kind of judges our clinical decisions based on our own sort of countertransference or nervousness about it, and it's not based on the true clinical need of the patient. And so I've certainly had a couple of patients that are on both. It's been safe. I haven't seen any adverse effects or side effects. And as long as they have both diagnoses, we want to make sure that we're kind of treating it from all angles so that they can really be successful in what they're doing.
Thank you so much for your time today, Dr. Sanchez. You have gotten a lot of thank yous and kudos in the chat. So this has been very informative and very much appreciated. If there are additional questions, you may email those to Nikki Millward. Her email address was your confirmation email. So email those to her, and she will get those to Dr. Sanchez and respond to you in kind.
Yeah, definitely.
Thank you all for your attention today. And again, thank you so much, Dr. Sanchez. Everyone have a wonderful day.
Thank you so much.